All right, so thanks for joining us at 11 a.m. on a Sunday. We're going to go through pathology of the repro tract today. I'm going to be totally honest with you, pathology is not very high yield in repro. There's a couple key conditions that you have to know, a couple buzzwords, a couple like medical emergencies that you have to be aware of. But on the general, it's not the highest yield, and a lot of it is just knowing of conditions and knowing common presentations and what the differentials would be, but you don't have to know much about diagnosis and management at all. So we'll start with amenorrhea. So amenorrhea can be split into primary and secondary amenorrhea. Primary amenorrhea is defined as failure to menstruate by age 16 with normal secondary sex characteristics, or by age 14 with no signs of sexual maturation. That's in contrast to secondary amenorrhea, which is where they've had periods in the past, but now there's been an absence of 3 consecutive menstrual cycles if they're normally regular, or for 6 months with no period if they normally have oligomenorrhea. The causes overlap a lot between the two, and you can kind of think of them in terms of the level where they act. So we know that menstruation is controlled by this sort of hypothalamic pituitary axis, with the hormones coming down from the hypothalamus, signaling to the pituitary to release LH and FSH, and that then signals the ovaries. At the hypothalamic level, you want to think about things that are very systemic stresses. So very low body weight, severe stress, severe diet restriction, really heavy exercise. And then in primary amenorrhea, you can also get Kalman syndrome as a cause, whereas secondary is just going to be those stresses. At the pituitary level, you're thinking more tumor. And again, this can be causing primary or secondary amenorrhea. But for secondary, you also want to think about infarction, typically happening during labor. So if the classic story is like someone who's just given birth and then after their baby, they just don't recover a period. And it's because they've actually had some pituitary infarction, hypotension during their pregnancy. At the ovarian level, PCOS is the cause. And then if it's primary, you've got to think about congenital things like Turner's syndrome. For secondary, it's more thinking about early menopause. And again, age will play a factor here. So if it's someone older, you'd think about early menopause. If it's someone who's very young presenting with primary amenorrhea, you typically think more congenital things. And that's the ones that are bolded here. The uterine level is like really low yield, I really wouldn't worry about, but you can have gonadal dysgenesis, which is just like structural abnormalities that prevent a period, or androgen insensitivity. And then obviously a differential for any kind of amenorrhea is going to be constitutional delay, which is just someone's a late bloomer. Secondary uterine level is a little bit more important because obviously you've got to think about pregnancy as a cause, and then systemically breastfeeding will also be a cause. So for like 6 months or so after someone gives birth, when they're breastfeeding a lot, you get suppression of the hormones here, and therefore they get amenorrhea. And then thyroid issues, you guys will already know from your endocrine topic that can cause amenorrhea as well. Okay, PCOS. So PCOS, just know like the bare bones, the important stuff. I know that like PCOS is very confusing and you can go into endless depth with it, but I think this is really the most important stuff to know. So the diagnostic criteria of PCOS is any two of hyperandrogenism, so high levels of testosterone, oligo or anovulation, so no period, and polycystic ovaries on ultrasound. And the classic features kind of fall into this triad of insulin resistance, and that causes truncal obesity, high LH, causing your features of high testosterone, so hirsutism, oily skin, acne, and then low FSH, and that's what causes your oligo or anovulation and infertility as a consequence. The management, you can go, there's a lot of depth, but typically you'd just say diet and lifestyle changes, because weight loss does help improve cycle regularity and decrease the risk of diabetes. And then the mainstay of treatment is the combined oral contraceptive pill, because that not only helps to regulate the menstrual cycle, but it also manages some of the hyperandrogenism. So it takes away some of the unpleasant effects. The next two slides are just lists of differentials. I really wouldn't worry too much about this, but if I think there were active learnings on these presentations, so I just threw in the conditions that you would want to think about. So menorrhagia, or heavy bleeding or abnormal bleeding, you want to think about local causes and then systemic causes. So locally, you can get infection, you can have polyps growing in the uterus. Adenomyosis is endometrial tissue growing in the uterine wall. It's kind of like endometriosis, but inside the wall. And then you want to think about growths, benign or malignant. Systemic stuff is really just like bleeding disorders. So someone might have a heavy period if they have a coagulopathy, and endocrine stuff. So remember that hypothyroidism is a cause of menorrhagia. Pelvic pain, I have bolded ectopic pregnancy, and that's because if you take nothing away from this slide, just remember ectopic pregnancy. Nothing else is really high yield in your year at all. But things that you can think about, again, organize it anatomically. So you've got ovaries, you've got the fallopian tubes, you've got the uterus. At the ovary level, you're thinking about growths. So whether that's a cyst, so a fluid-filled growth, or a malignant growth causing pain, or ovarian torsion, which is bad. It's like the female version of testicular torsion. That is kind of a red flag. Tubal stuff, so fallopian tubes, the main one is ectopic pregnancy, which we'll talk about. But you can also think about pelvic inflammatory disease, which is basically a complication of STI. So the inflammation proceeds like up the genital tract. Uterine stuff, it's like the same as the causes of bleeding. And then anytime someone presents with pelvic pain, you have to think about everything in the region. So including GIT, appendicitis probably being the big one if you're thinking right side, diverticulitis being the big one if you're thinking left side. And then urinary stuff as well, renal stones, UTI, all of that. So when someone presents with pelvic pain, if you're doing a history, you need to do systems review from everything in the pelvic region. So repro, genitourinary, GIT. Ectopic pregnancy, probably the most important pathology to know in repro, really. So this is implantation and maturation of a fertilized embryo outside of the uterine cavity, typically in the fallopian tubes. And the issue is if they implant in the fallopian tubes, they can rupture, and that causes massive internal bleeding. And the bleeding just does not stop until they get surgery. So this is a big medical emergency. They typically present with abdominal pain, and then there are other symptoms that you can have. So they might have PV bleeding, pervaginal bleeding. They might know that they're pregnant, or they might have features that suggest pregnancy, but not always. And so the takeaway message is that if a female presents with abdominal pain, you have to rule out ectopic pregnancy. It's like pregnant until proven otherwise for all females of reproductive age. If the ectopic has ruptured, it's like very, very bad. They'll go into hypovolemic shock, pale, cold, lighthearted, tachycardic, low blood volume. And they might complain of urge to defecate, which is kind of a random niche thing, but the blood will pool in the pouch of Douglas, and that actually puts pressure on the rectum and causes that kind of sensation. But for the most part, they just present with abdo pain. So any female presenting with abdo pain needs a pregnancy test to rule out ectopic pregnancy. Really easy, beta HCG, and that will rule it out. Menopause. Menopause is not really a pathology because it's normal, but it causes unpleasant symptoms. So we've grouped it in here. The term menopause gets thrown around a lot, but it does actually have a very specific meaning. It specifically refers to the final menstrual period. So the last period that a woman has, obviously if they've not had a hysterectomy, that would be very different. The average age of menopause is 51.5 years. Beyond menopause, there's like time periods that you look at, and these have different terms. So perimenopause is really referring to from the onset of cycle irregularity through to 12 months after the final menstrual period. Menopause transition is just from the onset of cycle irregularity to menopause, and then postmenopause is obviously from the menopause onwards. By onset of cycle irregularity, we mean like typically prolonged cycles. So usually throughout their life, women will have a fairly regular cycle length, And then as they start to approach menopause, the periods might be fewer and far between. So they get longer and longer cycles until eventually they just have no further periods. They might also have irregular periods, lighter, heavier periods, and other symptoms of estrogen insufficiency or excess. So early menopause is also called premature ovarian insufficiency, and that's defined as the cessation of ovarian function before 40 years of age. It's most commonly idiopathic, which means we don't really know why it happens, which means you don't have to worry about why it happens. But there are some secondary causes that you have to be able to think of. So physical insult is probably the main one, and that kind of makes sense. Like if you think of your ovaries as egg sacs, and you think of all the things that could potentially damage the eggs, then you're going to get ovarian insufficiency at an earlier age. That's kind of how I think of it. So things like radiation, chemotherapy, viral infection, smoking, surgery, anything that can cause damage to the area, essentially. There are also genetic causes. Turner's syndrome, remember, is 45X, so just one sex chromosome, and they get short stature and gonadal failure. The other one is Fragile X syndrome, and this is an unstable repeat of DNA on the X chromosome, and that causes all sorts of physical and cognitive features, but it's quite commonly a cause of premature ovarian insufficiency. So definitely one to think about. And then there's some other stuff that you don't really have to worry about. Okay, consequences of menopause. This is pretty important, but also it's fairly common sense. I'm sure a lot of people know some of the common signs of menopause. I've kind of grouped it into sensory things vaguely, and then vaguely psychological and cognitive things, and then your late symptoms. So the sensory stuff, vasomotor symptoms, are your hot flushes and your night sweats. And apparently this is theorized to be because of a reduced thermoneutral zone. So your body's tolerance for extreme temperatures is decreased. So you feel cold easier, and you also feel hot easier. So they get these periods of feeling really hot and sweating, and then alternating with chills and clamminess. Clonidine is a treatment for hot flushes, but they don't really know how it works. Other signs that you get, formication is this crawling sensation on the skin, apparently very unpleasant, and they can get muscle/joint pains. In terms of psychological or cognitive things, anxiety, depression, irritability, a lot of people experience severe psychological symptoms. They also have fatigue and sleep disturbance. So insomnia can be a big problem, and also lessened memory and concentration and decreased libido. The later symptoms of menopause are where you start to get your vaginal dryness and urogenital symptoms. So the dryness is due to decreased production of the lubricating fluid, but also because of loss of elasticity and atrophy of the epithelium. It can cause painful intercourse, which is one of the symptoms that you ask about on a repro history, as well as itching and burning, and they treat it with a topical estradiol cream. They can also get urogenital symptoms, and that's your typical frequency, dysuria, incontinence type stuff, but that's pretty late and that's pretty bad. But the overall thing to know is that menopause diminishes well-being. In terms of long-term consequences, the two that you need to know about are osteoporosis and cardiovascular disease or metabolic syndromes. So osteoporosis is really a combination of factors, one of them being menopause, but there's also just the general contribution of aging. So as people get older, they typically exercise less, you get decreased stimulation of the osteocytes, and therefore less bone formation. People also get vitamin D deficiency. I don't know, they go outdoors less or something like that. And that causes reduced calcium absorption, secondary hyperparathyroidism, and again, increased bone resorption. The menopause contribution is to do with the decreased levels of estrogen. So estrogen is typically protective for your bones, and when that level declines, you get increased rank ligand, which decreases OPG, and that increases the activity of your osteoclasts. The combined effect of all of these three is that you have low bone mass and loss of bone architecture, and that will present as pathologic or low trauma fractures. So typically people who might bump their hip against the table and fracture their neck of femur, stuff that shouldn't normally cause fractures because it's so low impact. And the other presentation is spinal compression fractures. So back pain, loss of height, postural deformities. You think of like the little old ladies who are like very short and stooped forwards. It's because of actually spinal compression fractures. The other big consequence of menopause is cardiovascular disease. Weight change is not so much the mechanism, it's more to do with weight distribution. So during menopause, weight distribution changes, and fat tends to be deposited more centrally, so abdominal, intra-abdominal adiposity, and that contributes to atherosclerosis. There is also this menopausal metabolic syndrome with dyslipidemia, insulin resistance, and hypertension and chronic inflammation that apparently increases the rate of atherosclerosis as well. But I don't think you need to know too much about the mechanisms here, just to know that this is a risk with menopause. Okay, on the other end of the spectrum, delayed or absent puberty. So this is talking about females and males. So we talked about primary amenorrhea already, which is kind of a part of delayed or absent puberty, but this is talking more broadly, females and males, and you can classify it into 3 causes. The first is if it's non-pathologic or transient. So they are just a late bloomer. There is no actual issue happening. The others are divided into hypogonadotropic and hypergonadotropic. And you can think of it as primary failure and secondary failure. So your hypergonadotropic or your primary failure is an issue with the gonads. So the issue is in the gonads, and as a result, you've got overproduction of LH and FSH to try to compensate. So if you did a blood test, you'd see high LH and FSH, and that indicates it's a hypergonadotropic hypogonadism. The other side of that is secondary failure. So if the issue is higher up at the pituitary or hypothalamus level, and as a result, you're going to have low LH and FSH, and that's the cause of the hypogonadism. In terms of hypogonadotropic, you're looking at pathologies of the hypothalamus and pituitary stalk. So they can be divided into congenital, acquired, and functional. So remember, your hypothalamus is going to be that systemic functional issue where you've got like intense stresses, not enough food, malnutrition, intense exercise, things like that. Whereas your pituitary stalk, you're more thinking CNS tumors, so pituitary tumors, or congenital malformations, or Kalman syndrome, which we'll talk about as well. Hypergonadotropic, just think of your 2 like chromosomal abnormalities. So Klinefelter syndrome, XXY, they have small testes, no sperm count, low testosterone. And Turner's syndrome, short stature, no functional gonads. Probably an important note, Turner's syndrome would be phenotypically female. So you're looking at a female, whereas Klinefelter's is a male that you're looking at. Okay, Kalman syndrome. So this is congenital GnRH deficiency, and it's caused by a failure of those neurons to migrate into the hypothalamus. The main symptoms to know is the absence of puberty and also loss of smell, hyposmia or anosmia. And that's because the failure of the neurons to migrate actually disrupts the olfactory nerves going through the cribriform plate as well. Hypoplasia of the olfactory lobes, you're not going to see on a clinical exam, but that's something to think of as well. It's 4 times more common in males than females, and the treatment is basically hormone replacement to try to mimic puberty. So they use gonadotropins first, HCG, which is similar to LH, and FSH, and that stimulates testicular growth, it establishes fertility, kickstarts things, and then after 5 years, you start to give testosterone for virilization, and that's going to give like the secondary sex characteristics, the hair growth, all of that sort of stuff. Androgen deficiency. So this is kind of like the broad category where Kalman syndrome is a specific variant. So androgens, they're responsible for establishing and maintaining virilization. People who have deficiencies, they'll have general symptoms, they'll have sexual symptoms, and they'll have organ-specific symptoms. So the general stuff is tiredness, fatigue, poor concentration. It's very vague, non-specific. Sexual is decreased libido, decreased ejaculation, and erectile failure. And then organ specific is actually quite similar to menopause. So decreased muscle mass and strength, osteoporosis and fractures, increased fat mass, and CBD and metabolic stuff. The treatment is pretty straightforward. You just give them testosterone. Okay. Male infertility. So infertility in general is the absence of conception after 1 year of regular unprotected intercourse. So it can obviously be a result of male or female infertility. But apparently 1 in 20 men are subfertile and 60% with no identifiable cause. So it's more commonly an issue with male infertility. Male infertility, there's 2 important categories that you really need to know about. The other 3, not so important. So it's most commonly an issue with spermatogenesis, and within that, most commonly idiopathic or genetic. It can also be acquired, so it can be a result of drugs, toxins, infection, radiotherapy, all that sort of stuff. The second most common category would be obstruction. So there's a condition called congenital bilateral, BCAD, bilateral congenital absence of the vas. So they have no vas deferens. They might have had a vasectomy, and STI can cause obstruction as well. They're really the main ones to know. Intercourse issues is more to do with erectile and ejaculatory dysfunction, which we will talk about, but it's less common. And then there's like anatomical and psychosexual issues, which are vague. Sperm antibodies, don't worry about. And endocrine, very rare as you can see, but for some reason we talk about it a lot. So that this is your Coleman's, this is your pituitary tumor causing gonadotropin deficiency. It's not really a treatment, but the way they typically bypass it, if there is functional sperm production, is intracytoplasmic sperm injection. If male infertility is suspected, it's diagnosed with semen analysis and hormone levels. So semen analysis will look at the production of the sperm, so the number, if you are actually producing sperm, and also the motility and morphology, looking at the health of the sperm. Hormone levels is going to give more of a clue though to the cause. So if you have normal FSH levels, it's probably an obstructive cause, because it would suggest that there is normal sperm production, but the sperm is just not making its way out. Whereas high FSH levels, that indicates that you have an actual primary testicular problem. So think back to like hypergonadotrophic hypogonadism, where it's a primary failure, you get higher levels of your stimulating hormones to try to compensate. Infertile males, they should also be investigated for testicular cancer because it's a higher risk, and also causes androgen deficiency, chromosomal anomalies. Erectile dysfunction. So this is consistent or recurrent inability to attain and or maintain an erection sufficient for satisfactory sexual activity and intercourse. It's a very long-winded definition. But the main causes that you have to know are 3: cardiovascular disease, diabetes, and prostate surgery. So JJ, I believe, has already talked about like the mechanism of an erection. Essentially, it's a combination of stimuli coming through various nerves, including the cavernous nerve, importantly. And that triggers these arteries here, the cavernous arteries, to dilate and fill with blood. That causes the sinusoidal spaces around here to dilate and fill with blood. And that compresses on this deep dorsal vein here, which means that you're not only getting more blood inflow, but you're blocking the outflow. And that's what triggers an erection. So you can kind of think of it mechanistically of like what might cause issues along that pathway. So you can have issues with the blood flow, and that's going to be cardiovascular disease or atherosclerosis. The blood can't flow in. And weirdly enough, this can be actually a common first presentation of like really bad atherosclerosis. Diabetes as well. This can be a common first presentation of undiagnosed diabetes, and that's through diabetic autonomic neuropathy. So the autonomic nerves here are very important in playing a role. And so if you have dysfunction of those nerves from chronic undiagnosed or untreated diabetes, it can cause erectile dysfunction. The other one is prostate surgery. So if someone has had a history of prostate cancer and they've had surgery for that, that surgery can damage the cavernous nerves because they're in close proximity, and those nerves are important for signaling here. So that will cause issues as well. The other ones are less important. Drug-induced antihypertensives is kind of like blood flow again, and then hormonal and psychogenic. Testicular problems. So there's a lot of testicular problems essentially, but I think these are the two most important ones to know about, or the two most common ones to really think of. So varicocele, this is your bag of worms as they describe it. It's dilation of this campaniform venous plexus here, the veins that are responsible for draining the testes. So if they get blocked, the blood pools in here and it causes this bag of worms feeling, apparently. It's more commonly going to happen in the left testicle, and that's because the left vein is longer. And if you remember your anatomy, the left testicular vein drains at a right angle into the left renal vein. So if you've got a right angle like this, it's more likely to cause issues with backflow. The consequence of varicocele, and the reason why it's really an issue, is that this pooling of blood disrupts that countercurrent cooling method, which means that you get increased temperature around the testes, and that affects sperm production and can cause infertility if it's untreated. The other testicular problem to really know about is torsion, and this one's really important, and it's in a medical emergency because infarction can happen within 6 hours, and if that happens, the testis can't be saved. So what happens is the spermatic cord twists on itself, and that strangulates the testicular artery, and within hours that will cause necrosis. The presentation is sudden, severe, worsening pain in the lower abdomen or testis. So the two red flag conditions you have to know are ectopic pregnancy in females and torsion, testicular torsion in males. If anyone presents, particularly younger people, presents with abdominal pain, you have to mention those. Obviously all your GIT stuff, but you need to mention those because they are medical emergencies. In terms of examining for torsion, the testis will sit higher, the scrotum will be all red and swollen, and the cremaster reflex will be absent. So that's where if the inner thigh is stroked, the testis should retract upwards. And obviously because it's already been retracted, there won't be any further retraction. The management is surgery. The diagnosis is actually also surgery. If there's clinical suspicion, they go to surgery. Prostate problems. So prostate problems are divided into benign, so not so concerning, and malignant, more concerning. So your benign is BPH, benign prostatic hyperplasia. So this is benign, non-malignant growth of cells in the transitional zone. So here's your diagram of the prostate sitting around just under the bladder here. And you can see there's a transitional zone, a central zone, and a peripheral zone. And the transitional zone importantly surrounds the urethra. So this is why BPH causes its symptoms. If you have growth of cells in this region, it's going to compress on the urethra, and that causes storage problems. So they can't hold in their urine because of the obstruction, frequency, urgency, nocturia, and voiding problems. So poor stream, hesitancy, dribbling, all of those symptoms that you ask about on a urinary history. And BPH is very common with advancing age. Apparently the majority of men have it by the age of like 70. It's diagnosed by a DRE, digital rectal exam, and it should be smooth and regular. That's the most important thing. It will be enlarged, but it should be smooth and regular. PSA, prostate-specific antigen, is something that we use to screen for prostate cancer, but just to note that it can be mildly elevated in significant BPH. This is like decreasing in yield. So by the time we get to treatment, you really don't have to worry about treatment. But if for interest, the treatment is transurethral resection. Basically, they stick a tube up here and they literally just scrape away bits of the prostate. It's quite strange. And then prostate cancer is your malignant version. So this is different in that it originates from the peripheral zone. So there's a lot of concern with BPH because people worry that it predisposes to prostate cancer, but it actually technically doesn't because it's a completely different area of the prostate. So BPH is in the transitional zone, prostate cancer is in the peripheral zone. And you can see because it's here, it may not cause the same urinary symptoms. And it might not be diagnosed until a DRE is performed. It's the most commonly diagnosed cancer in men, apparently. And the main thing that differentiates it from BPH is that on DRE, the prostate gland is irregular and hard. It's like bumpy. PSA will be elevated. Prostate cancer is concerning because it can spread to a lot of places, but most importantly, it can spread through the bats and venous plexus to the vertebral bodies, the spine, and up to the brain. So prostate cancer might not seem that major, but it can often metastasize to the brain. Treatment is radical prostatectomy, basically cutting it out. But remember that this causes erectile dysfunction, apparently with a rate of like 50%. So it's quite bad and often not ideal. Cancer spread. So in anatomy, they love to ask about the lymphatic drainage. They love to ask about where cancers are most likely to spread. I think it's really not that important, aside from knowing which ones will drain superficially to the superficial inguinal nodes that you can palpate on exam versus the ones that drain deep. Because if they go to the deep nodes, you're not going to be able to palpate anything all the way up until it gets to like the sentinel node, at which point it's spread quite far. So the ones in red here, they drain deep. So cervical cancer, uterine cancer for the most part, testicular cancer, prostate cancer, upper anal cancer. You're not going to be able to palpate lymph nodes for that. Whereas the ones in blue here, they do drain to the superficial inguinal nodes, so they may be palpable. So these ones, it's pretty easy to remember because it's stuff that's just like superficial and low down. So perineum is like skin, lower anal canal is like, you know, external surface. And then scrotum and vulva are also quite like external. So I feel like if it's very external, it's going to drain superficially, whereas your cervical, uterine, like stuff that's more internal tends to drain deeper. The exception to that is ovarian. So the ovarian tumors, they can technically drain to the superficial inguinal lymph nodes as well, but it's uncommon. And with the uterus, the fundus and the fallopian tube, so the upper portions can drain to the superficial inguinal nodes, but it's also less common. So you're typically just thinking superficial things go superficial and deep things go deep. Okay, that's your pathology. Clinical skills and OSCE. You need to know how to do a repro history, and then you need to know a lot about contraception, which is a pain to learn. But this is your repro history. I've split it into questions that you would ask everyone, questions that you would ask females only, and questions that you would ask males only. As you can see, it's a lot of questions. So I've tried to kind of categorize it a little bit so it's a little bit easier to remember, but this is the pain. And unfortunately, you can actually get asked to do a repro history on OSCE. Apparently this did come up once, and apparently it was very poorly done, understandably. So the questions that you would ask everyone, the first thing you want to know is to be able to like quantify the type and kind of sex that they're having. So what is their sexual orientation? Who are their sexual partners, one or multiple, and what kind of intercourse are they having? Under this also, you would want to know, is it protected? So are they using contraception, and what type and compliance? Because people will be like, yeah, you know, I take the pill, but then they're forgetting the pill like every second day. So that doesn't really count. And then you want to know about risk factors for STIs. So when you're asking about contraceptive use, it transitions pretty easily to condom use. And that's a question of its own because condoms are used for contraception, but importantly, they protect against STIs, whereas other contraceptive methods don't. So definitely one you have to ask about. And then you think about other STI risk factors. So sexual intercourse overseas, known contact, and then IVDU, tattoos and piercings. These gray ones here are kind of to do with hormonal changes. So libido change, galactorrhea, breast development, and then you're thinking like infection type stuff. So systemic symptoms of like fever, sweats, and weight loss, which is kind of like cancer/infection. And then your UTI symptoms, dysuria, frequency, incontinence, hematuria, and discharge. And if they have discharge, you've got to talk about like, is it normal discharge? Is it abnormal? Is there itching? Is it bloody? Things like that. When it comes to females specifically, again, first of all, you want to like quantify things. So you want to quantify their menstruation and their menopause and their pregnancies. So menstruation, you want to know pretty much everything start to finish. You want to be able to like take a calendar and put in where this woman probably had her periods. So you need to know, when did she first start getting periods? Menarche, age of first period, all the way through to the last normal period. Obviously, if they're like of menopausal age. So when did they last have a regular period? And then in between, you need to know what a normal period was like for them. So a cycle length, which is the time from the beginning of one period to the beginning of the next. It's typically like 28-ish days, but it rarely actually is. So you ask them roughly how long their regular cycle was and if it was regular, because some women just have irregular periods their whole life, especially with PCOS. And then you want to know about the bleeding. So how long did they bleed for? 3 to 5 days, I think, is average. And then how much did they bleed? Apparently a good way to ask that is to ask about how many pads and tampons they use. But that obviously relies on there being a normal number of pads and tampons, which I don't know if there is. So you just want to really be able to gauge if it's abnormally heavy or if it's very, very light or absent. And they'll typically be able to tell you if it's abnormal for them, which is usually a good gauge. You also ask about bleeding in between periods, which would be your abnormal spotting. So once you've understood everything there is to know about their menstruation, then you want to ask about, have they hit menopause? So last normal period is part of that, but also symptoms of menopause. Hot flushes, formication, vaginal dryness, mood changes. Obviously, if someone's very young, like 30s, you're probably not going to ask them the menopause questions. And that's where you have to think quite a lot in the repro history of who your population is. But that's sort of thrown in there for the older women. And then you want to know about pregnancies. So pregnancies being like breaks in menstruation. So how many pregnancies they've had, and importantly, how many of those pregnancies have been deliveries, and then if they've ever had miscarriages or ectopics, because previous ectopic is a risk factor for further ectopics. Then in red, we've got like pain questions. So dysmenorrhea is pain during the period or just before the period specifically. Dyspareunia is pain during intercourse specifically. And then also you want to ask about general pelvic pain. And that might be something like endometriosis or like pelvic inflammatory disease. And then again, hormonal type things, thinking about PCOS, if they've had hyperandrogenism. God, these words are so hard. Hirsutism, acne, and weight gain. And then screening for cancers, cervical screening, breast exams. In males, there's a lot less to ask. You want to ask urinary symptoms, you want to ask testicular stuff, and you want to ask like sexual function, basically. So nocturia, and then obstruction symptoms, thinking about BPH. So your poor stream, hesitancy, dribbling. Then you want to know, have they had any testicular problems, pain or lumps, thinking about torsion, thinking about varicocele, thinking about cancer. And then ejaculatory problems. Do they have erectile dysfunction? Do they have premature ejaculation? So that is everything that would go into a comprehensive repro history. Very lengthy. Then we get into contraception. So I don't know if you guys got it this year, but you probably did. We had like a clinical skills table, which spanned like many, many pages, going like in depth for every contraceptive method. And a lot of it was very repetitive, which is why I think it can probably be organized better. But I think these are probably the key concepts that you really need to know for contraceptives, okay? So they are broadly categorized into types, one being long-acting methods, but reversible still, another being short-acting, barrier methods, emergency contraception, so your morning after pill, natural methods, and then permanent methods. And each of them has a couple key sort of buzzwords in terms of what kind of populations they would be recommended for. And then we'll go into the specific types as well. The reason you have to know contraceptives is for two. One, they can ask you to do an explanation OSCE station, in which case it would most likely be the hormonal IUD or the combined oral contraceptive pill, because they're the most common forms of contraception. The other type of questions that you can get is for EMQs. So they'll give you like a massive list of contraception. They'll give you a couple lines about different women, and you have to like pick the most suitable contraception for them. And so for that, it's very buzzwordy. It's just important to know some of the key pros and cons of each. So long-acting methods. The biggest pro is that they are very convenient. You set it and forget it. They last like 5 to 10 years or 3 to 10 years, depending on the type. And it's very easy. It's very convenient. If the stem says something about like a woman's been on the pill, but she's very forgetful, you'd put them on a long-acting method. The downside is that they need to be inserted by a qualified doctor, and there is a slight risk of infection at the time of insertion. But generally speaking, these are the most effective, the most convenient contraceptive methods, and they would be recommended for most like young females not wanting to get pregnant. There is a hierarchy of effectiveness, but I wouldn't worry about it. It's only like tiny differences. They're generally all super effective. Your shorter acting contraceptive methods, 2 pills and then 2 other things. So your pills are your combined oral contraceptive pill and your mini pill. And the difference between those is in the hormones that they contain. And then you also have the vaginal ring or the Nuva ring, and you have the Depo-Provera injections, which we'll talk about specifically. But the shorter acting methods on the whole are good for people who want more flexibility, or people who say they might potentially want to get pregnant soon, in which case it doesn't really justify putting in an IUD or an implant on. They do, however, have lower efficacy, somewhat intrinsically, but also because of human error. Obviously, with the pill that has to be taken daily, there's a lot of margin for error there. The barrier methods. The barrier methods include mainly the male condom, but also diaphragm and female condom. And the most important thing to know with barrier methods is that they are the only method that provide STI protection. So if the stem says something about someone who has multiple sexual partners, or they're having sex with people that they don't know well, barrier method. Emergency contraception, obviously not ideal, not super effective, and the effectiveness decreases the longer time has passed after intercourse. But this is the best contraceptive method for preventing pregnancy after sex. So if someone realizes afterwards that they've had unprotected sex, this would be the only main option. Technically, copper IUD can be used as emergency contraception, but like then you get all the issues with copper IUD. We'll get into that. Natural methods and permanent methods are pretty low yield. Natural methods, you pretty much never really recommend it, but you've got lactational amenorrhea, which is just the natural amenorrhea that they have when breastfeeding. So I wouldn't even really call it a contraceptive method. Natural family planning, which is basically planning to have intercourse when a woman is not fertile in her cycle, obviously requires a lot of thought, requires a lot of understanding of a person's cycle, and people also have the lowest libido at the time when they're least fertile. So it's really just very restrictive. And then the last natural method is withdrawal. Not good, don't recommend ever. Permanent methods, sterilization, obviously like very effective. Some would say 100% effective. And this is only good for people who are absolutely 100% certain that they don't want kids. So the stem will be something like, you know, someone who already has a couple kids, they're like middle-aged and they 100% know that they don't want any more, then you would consider sterilization. Mechanism of action. So this made my head spin a little bit in second year because it's kind of hard to wrap your head around which ones do what because they all sound similar. But I've split it into your hormonal ones and then everything else. So the LARCs, your long-acting reversible contraceptives, and short-acting hormonal methods, everything acts by a combination of these 3 mechanisms. So one of them is thickening of the cervical mucus plug. So that's here. You've got a mucus layer here, and if that's thickened up, it essentially acts as a barrier for sperm getting through to the egg. The other possible mechanism is through preventing uterine implantation, and that's often by thinning the uterine wall. And then the other one is stopping ovulation each month, and that's stopping the actual release of the egg. Most of these methods do all 3, but your IUDs will only do the first 2. And the reason for that is because IUDs act locally only. They don't have systemic effect. That's a good and a bad thing. So because they don't have a systemic effect, they don't have any effect on ovulation each month. but they do the other two things. The other exception is the mini pill, and I just think that the mini pill, it's mini, not very good, it's kind of flimsy, and so it only does the first one, and then it maybe does the other two. So it's like, it's not as good. Whereas your Implanon and the other short-acting methods do all three. The other ones are much easier to learn. So emergency contraception, it's a very high dose of hormones, and the aim is just to stop the ovaries from releasing an egg. Your barrier methods, very intuitive, make a lot of sense. They either stop the sperm from entering the vagina or they stop the sperm from entering the uterus. And then sterilization, again, makes a lot of sense. If you cut the fallopian tubes, then the ovum can't reach the sperm. If you cut the vas deferens, the sperm can't reach the semen. Okay, let's go in a little bit more depth now. So long-acting reversible contraceptives. There's 3 options, and I've put pictures here. So we've got Mirena, which is your hormonal IUD. You've got the copper IUD, non-hormonal, and then you've got Implanon, the rod that goes in the arm. The Mirena is a small plastic device impregnated with progesterone and inserted into the uterus. And remember, it only acts locally. Both the IUDs only act locally. It lasts 5 years, and because it acts locally, the pro of it, I guess, is that there's very minimal side effects and interactions. And this one here is faculty's favorite. So if you have a stem where it's like, there doesn't seem to be much pointing towards any particular type of contraceptive, and you're like, really, they could use anything? The answer is probably Mirena, just because it's the most effective, the most convenient, and it has very few side effects. Copper IUD is less good. So side effects include heavier periods and more painful periods. So it's often not very well liked, but it does have a couple specific uses. One is if the question stem is like, this person doesn't want hormones, or they have like contraindications for hormones, then their options are really only barrier method and copper IUD. So if they want something long lasting, it would be copper IUD. And this lasts really long, 5 to 10 years. The other niche use of copper IUD is for emergency contraception. It's actually very effective as an emergency contraception. And that's sort of in contrast to the morning after pill. Implanon is the rod here that gets inserted subdermally into the arm. It's about 4 centimeters long, and this does act systemically, unlike the IUDs. So because it acts systemically, it does all 3 of the things, but it has side effects. And these are all your classic sort of hormone side effects: weight gain, sore breasts, headache, bloating, mood swings, skin changes. This also lasts the least long of the 3. It only lasts 3 years, but it does have the highest efficacy. So it does have a place as well. But I think IUDs, Mirena especially, typically tend to be the favorite. For shorter acting contraception, it's split into 2 types: estrogen and progesterone, or progesterone only. Estrogen and progesterone, they have the benefit of shorter, lighter, less painful periods, but a lot of side effects and contraindications for estrogen. And we'll talk about those for the COCP. So the main one here is the combined oral contraceptive pill. This is a daily pill. It's the most commonly used form of contraception in Australia, probably because it's easily accessible. And it does decrease the chance of uterine and ovarian cancer, but prolonged use can increase the chance of breast cancer. So it's really a toss-up. The other short-acting method that uses both hormones is the NuvaRing. Got a little picture here. So this is like a little ring that sits here inside the vagina, and it contains both estrogen and progesterone. And you kind of follow the same timeline as the combined oral contraceptive pill. It's inserted for 3 weeks to have its effect, removed for 1 week to have a period, and then a new one is inserted. Whereas for the pill, you take active pills for 3 weeks, take placebo pills or sugar pills for 1 week to have a period, and then repeat. So it's that 4-week repeating cycle. The progesterone only methods, you can have, again, a pill, and the alternative to the pill is an injection. So the pill here, the mini pill, it's preferred over the combined oral contraceptive pill only if someone has contraindications to estrogen. Otherwise, in all other aspects, it's inferior to the combined oral contraceptive pill. and you have much less flexibility with this. It has to be taken right on at the same time each day within a 3-hour window, whereas combined oral contraceptive pill, you have a little bit more leeway. The periods here can be irregular or absent. They might have spotting and they might have headaches or sore breasts. I wouldn't worry too much about those. You can pretty much rattle those side effects off for any contraceptive, pretty much. The other option is Depo-Provera or Ralovera, which is injections that are given every 12 weeks. They look something like this. These are pretty much never recommended, and I think they would probably never be the answer for an EMQ. So you can probably rule it off. And that's because they have a lot of side effects. People get more frequent periods, breakthrough bleeding in between those periods, weight gain, satiety, decreased libido, lots of bad things. These basically used to get used for women with intellectual disabilities, which when you think about it is kind of unethical, but a separate matter. These are pretty much never used now, so do not recommend. Okay. So more depth on the combined oral contraceptive pill, because this was a practice OSCE station for us, and I think it very well can be an OSCE station. And also it comes up in multiple choice questions a lot, particularly this bit that I've bolded here. And so it's quite high yield to know, actually. So I've split explaining it into how it works, how to use it, how effective it is, and then good, bad, and contraindications. So in terms of how it works, if this was an OSCE station, for full marks, you should really draw a diagram. So you'd like pull up some paper, draw a little uterus and some fallopian tubes and like a little cervix and vagina, and you would say that you take this pill every day. It has 2 hormones in it called estrogen and progesterone, and they work by the 3 mechanisms. So increasing the thickness of the cervical plug, so the mucus that blocks the sperm entering, by stopping the release of eggs from ovaries each month, and then by actually thinning the lining of the womb, so that if an egg gets through and if a sperm gets through by some off chance, it will actually not be able to implant. And so it's a 3-way method. How to take it. So how to take it, again, for full marks, you should like pull up a pill packet. So on an OSCE, they would probably provide you one if it was in person. I don't know how they'll do it online. But you would have a little pill packet and you would say there are 21 active pills, there are 7 inactive pills. You start in the colored section on whatever day of the week it is that you're starting, and then you follow the arrows through to take all the active pills, the inactive pills, and you come back up until you finish the packet, and then you start a new packet. Should be very straightforward. The issue is that people forget. And when people forget, you've got to think about how much they've forgotten. So if they've just missed 1 pill, which confusingly means it's been less than 48 hours since their last pill. If they've missed just 1, that means they just take the missed pill straight away, continue as normal, and they're still protected. So this is the advantage of the combined pill over the mini pill. You actually have quite a lot of leeway. So if they forget one, let's say they take it 8 p.m. every night, and they forget one particular night, and the next day it gets to like, I don't know, 5 p.m. the next day, they can still take that pill, continue as normal, and they'll be protected. However, if they miss 2 pills, so it's been more than 48 hours since the last pill, you take 1 pill straight away, continue as normal, but they're not protected. So they have to use backup contraception for 7 days. And 7 days is really like the magic number for all of this pill stuff. So they have to take backup contraception for 7 days. If they've had unprotected sex in the last 7 days, they need emergency contraception. And the other 7-day rule is here. When they first start, they should use backup contraception for 7 days as well. The only exception is if they started on the very first day of their period, but that probably rarely happens. The one good thing about the combined oral contraceptive pill is that you have very good control. So they can skip a period if they want. And to do that, you just skip the 7 inactive pills and skip straight to the active pills again. The other important thing to know about is diarrhea and vomiting. So obviously this is a pill that's taken orally. If they then vomit, or if there's rapid transit with diarrhea, the pill may not be effective. And so they either have to take a spare pill from a spare packet, or they have to use backup for 7 days. In terms of efficacy, if taken correctly, it's very effective, 99%. But the issue is that it's not often taken completely correctly. Pros and cons and contraindications. So these can actually really be extended to really any estrogen method. So the good stuff with the combined oral contraceptive pill is it's non-invasive and very effective. The periods become regular, lighter, less painful, and can be skipped, and acne may improve, and it reduces the risk of ovarian and uterine cancer. The downsides, however, are your estrogen side effects, and that is all of this unpleasant stuff. The other downside is that there's no protection from STIs because it's not a barrier method, and it increases coagulability. So they have an increased risk of DVT and consequently PE. There is also a small increased risk of breast and cervical cancer with prolonged use. So when screening people for breast cancer, long-term oral contraceptive use is actually a risk factor. And then there's some drug interactions, which I wouldn't worry about too much. So they're your pros and cons. And then contraindications for any estrogen-containing method, migraines, because they will be worsened. Smoking over 35, I think because of DVT risk. Being very overweight, probably also DVT risk. Hypertension, heart or liver conditions, and family history of breast cancer for obvious reasons. Okay, so that's your hormonal stuff out of the way. Long-acting, short-acting. And then we get into the non-hormonal stuff, which is, thank God, a little bit easier from here. So barrier contraception, there are 3 types, really only one that is commonly used. You have male condom, female condom, diaphragm. Male condom, it's preferred because it's very cheap, very accessible, and less prone to user error. The downsides are that it can slip off or break during sex. And a lot of people don't actually know because they haven't been educated on use properly, but the male has to withdraw immediately after ejaculation to prevent leakage, and condoms can expire. So people will leave a condom like in their wallet, in their purse, in their car for months and months and months. And you actually have to check the expiry date before you use it, because if it's out of date, it's much more prone to breaking. And if it does break, they have to use emergency contraception. So you have to educate the patient to not reuse condoms, obviously, not to store them in a wallet or purse for too long, not to store them in warm environments, and also not to use an oil-based lubricant, because that can actually break down the material of the condom as well. The flip side of male condom is female condom, but it is less effective, it is more expensive, it is less accessible. Male condoms you can buy pretty much anywhere, right? Female condoms, you really have to go to like a pharmacy or like a family planning clinic. The other thing is they can be inserted before sex, which may be a pro or a con, I don't know, but they can be very tricky to use. So here's this little diagram. You've got 2 flexible rings, one on either end, and then like a little rod that is used as the applicator. And then you essentially insert it so that the upper ring kind of cups the cervix, almost like a diaphragm, and then the lower ring hangs loose. You can see here what a potential issue could be, and that is ensuring that the penis actually goes into the condom, because this has quite a lot of potential to slip and bunch. Which would obviously decrease efficacy. The diaphragm is more effective than the female condom, but again, more expensive, again, less accessible, and again, more prone to user error. So it's inserted with a finger and it sits just over the cervix like this, and it's actually used with a spermicide gel to, I guess, increase its effectiveness if sperm does manage to leak through. But the issues with it are they can be quite uncomfortable if they're the wrong size, and they can also be very prone to slipping if they're the wrong size. So if a woman has gained significant weight, has just given birth, and things are a bit dilated over here, they'd have to be refitted. And there is a bit of a learning curve with it, so they actually are recommended to use another form of contraception while they're learning to use this. After every use, they have to take it out, wash it, and check it for holes. Okay, we're on the home stretch. Natural contraception. Pretty much never the answer in EMQs, but just to know what they are. So lactational amenorrhea is that natural postpartum infertility. So remember, secondary amenorrhea, one of the causes was pregnancy. And that continues actually even for a short period after childbirth when the woman is breastfeeding. It is technically 98% effective, but only if the woman is amenorrheic and breastfeeding as the only form of food and drink for the baby, and it's been less than 6 months since the baby was born. So obviously this is not like a contraceptive method that you choose to use. It's just like something that happens to happen. Natural family planning means only having intercourse at times when pregnancy is unlikely. If someone has difficult, irregular periods, this is very difficult, if not impossible. And you basically always have to have emergency contraception on hand just in case. Withdrawal method, I suppose it's natural. It's not very effective. You may need emergency contraception, literally never the answer. Emergency contraception. So this is for protection after unprotected sex. It's basically a very high dose of progesterone. Technically can be taken up to 4 or 5 days afterwards, but it really should be taken as soon as possible to maximize efficacy. Can be purchased without a prescription, and there are some unpleasant side effects, which is why no one would ever go on the emergency contraception as regular contraception. So it causes nausea, bleeding, and potentially a late period. And the issue with the nausea is that if they actually vomit within 2 hours of taking it, they need to take it again. Copper IUD can also be used as emergency contraception, but I think it's rarely used for that purpose. And lucky last is sterilization. So sterilization, female and male. Pretty straightforward, pretty easy to understand. In females, it's tubal ligation, so cutting or banding the fallopian tubes, and that's obviously going to stop the ovum from making its way into the uterus. This is effective immediately. And it actually doesn't induce menopause because the ovary will still be functional as usual. A vasectomy is a little bit different. So obviously you're cutting a different area, you're cutting the vas deferens, but it's different in that it's not immediately effective. So people who've had a vasectomy, they actually do have to use alternative contraception for a little bit because you've got storing of semen in the seminal vesicle, right? So there's still going to be some sperm hanging out here and coming out for a little bit afterwards. And so they have to use alternative contraception until they've confirmed a sperm count of 0. If people are worried, this procedure doesn't really affect ejaculate volume or libido. Okay, that's everything for me. Any questions? Feel free to type in the chat. If not, I'll just stop screen sharing so Kevin can share.
Any questions at all? Any questions? If not, we'll go into micro. Micro is pretty short and also doesn't have too much stuff you really need to know. Micro, like all the rest of micro, really is predominantly like, what does it look like and what are some buzzwords? Because that's fundamentally all you need to know. But if there are no questions, we will get started. If you have any, just message any of us in the chat if you like it. Okay, so this is just a slide that's kind of just a general principles kind of area. They are very common for a variety of different reasons. A lot of them you can probably imagine yourself. So lack of education, taboo. They're asymptomatic, which is an interesting point, but also an important point because it can also lead to complications later down the line. They generally don't have a cure, but they are, for the large part, not lethal, which is good. People are unwilling to get tested and risky behaviors are sometimes hard to change. And as such, STIs are common. In some general principles, generally they are fragile, but that just means they have to be transmitted through close contact and direct transmission, which you would expect from a sexually transmitted infection. It's also possible to get multiple infections at the same time. So just because they already have one doesn't mean they won't have another. And in some cases, for instance, with HIV, it's actually more common for them to have or get HIV if they already have another STI, for instance, syphilis, something like that, just because there's more white blood cells there for those HIV viruses to infect. This is just a general overview of some microbiological causes of diseases. I think primarily the important thing is to know what these words all sort of mean. The organisms that affect or cause them are also good to know, but they are fundamental buzzwords, and we'll go through each of them specifically because they will have each of their own little clues. But cervicitis and urethritis is inflammation of the cervix or urethra, respectively. Vaginosis is disruption of the vaginal flora. It can cause an unpleasant odor and vaginal discharge, which I guess has to be abnormal or different to what they are normally expecting. Genital ulcers and pelvic inflammatory disease, which Elaine talked about a little bit, but they're not incredibly important, basically just scarring, I'm pretty sure, from these infections. But we'll go into those in a little bit of detail. So these are the viral causes of STIs. The three we'll talk about most are HPV, HIV, and HSV. Hepatitis B is a sexually transmitted infection, or it can be, but it's more important as like a hepatitic virus more than anything else. So we won't really touch upon that there here. So HPV. So HPV is very common. It's a double-stranded DNA virus. The important thing here is to know that it's HPV 16 and 18 can cause cervical cancer, and types 31 and 45 are also at increased risk. That, realistically speaking, is the more important facet of HPV, that it's a risk factor for cervical cancer, but also for anal cancer, vaginal cancer, penile cancer, and things like that. It's transmitted through skin-to-skin contact. That doesn't necessarily mean intercourse, but it can do. It enters through little cuts and goes to your blood. Importantly, it generates warts, and this is through viral proteins, which disrupt p53 and RB, retinoblastoma factor, or retinoblastoma, which should be familiar to you guys as tumor suppressor genes. And as such, if it can go into these genomes, it's more likely to cause cancer as a result, if it kind of chronically does that same process over and over and over again. It's got an incubation period of 1 to 6 months and is primarily just diagnosed by looking at the lesions. Like if you have a wart, you probably have HPV. Importantly, though, you're also looking at associated cancers done through cytology. So I'm not entirely sure that they're that common nowadays, but they're still a big thing, basically. So the pap smear, I can't say that word. Pap smears to detect epithelial changes. And this is to kind of just see neoplastic changes in early cervical cancers to kind of prevent the progression of, realistically, cervical cancer. Treatment, I guess, isn't really important at all, but you can have cosmetic treatment, which is just liquid nitrogen to kind of burn it off, I guess. And then you can have a vaccine as well. I'm not sure how it's used in public. I'm not sure if the other guys know if it's just a general thing people get given. I don't remember, but there's a vaccine that exists for it.
I think it's more commonly given to like younger sort of people. So like people, I think when we were school kids, actually, like teenagers, they gave us the HPV vaccine. Used to be cool for that. And now it's like, I think there's like a big thing about like how some Australian guy discovered it on the Gold Coast.
I think all girls now get it in like year 10.
I think it's even for guys now as well.
Yeah.
Sure. Yeah. Just know that one exists. And apparently it gets used a lot. I think I remember actually that he said it too. But yeah, it's one that exists. HIV. So this is also very common. I guess less common than HPV though. There are two types, HIV 1 and 2. Realistically speaking, only HIV 1 is relevant to Australia. HIV 2 is like this little virus, well, not a little virus, but a virus that's like constricted to like sub-Saharan Africa. So we don't really have it that much. There are a whole bunch of different genotypes, but also don't need to care about that. Importantly, it has a reverse transcriptase, which is what makes it a retrovirus, basically. It causes AIDS, as you'd expect, and it does this through infecting CD4 plus cells, but over a long period of time. So there's a list of cells which it includes, but basically a lot of your immune system affects. Importantly, the CD4 cells is what it kind of binds through. So GP120 envelope protein is this kind of like protein on HIV, which binds to CD4 with CD5 as an co-receptor to allow it to come in. There's another one, but that's not as important for you guys. It's like CXCC5 or something. It's also transmitted in bodily fluids. Again, it doesn't necessarily have to be sexual contact. It can be through blood, through blood products, which is such as like transfusion products, which doesn't really happen much anymore because we have a good screening program against that. But I guess in the earlier times, that was a thing. Needle sharing as well, although the risk on that isn't ridiculously high, but it's still a risk. And mother-to-child vertical transmission as well. Sexual transmission is highest from male to male, just I think because of the prevalence more than anything else. But also male to female is also something that can happen. Other STIs also increase likelihood of transmission, and frankly, that's just because when you have an infection already there, there's more immune cells kind of dealing with the original infection, and then HIV then hitches on to those immune cells that are already there, which is just more of a fun fact, I think, than anything else they're going to assess you on. So it goes through 3 sort of phases. You get this kind of graph that you get shown a bit, but I don't think it's like, I don't really think it helps that much. But in the initial phase, basically you have a massive loss of your CD4 cells, causing you have a profoundly weak immune system and a lot of virions. So basically your viral particles spike a lot. In that phase, however, you don't really get HIV specific symptoms or anything like that. It lasts a few weeks and it feels like a flu. So you really don't know, or some people won't know. Over time, your CD4 cells will recover and your HIV virions will decrease, but that will gradually come back against each other, basically, if it's not treated. This lasts years and it can increase the risk of opportunistic infections. And then at the end, you have AIDS onset, and it's heralded by the presence of AIDS-specific diseases or infections that are kind of not what you'd expect. So infections that are kind of in weird tissues, for instance, cytomegalovirus in the brain or the retina, are heralds of AIDS. There's a bigger list in the like kind of speaker notes if you wanted to look at it. I didn't think it was like that important. Basically, if you have an infection of a weird bit, it's like AIDS. And also tumors. So Kaposi sarcoma is like a buzzword for AIDS, but just because it's like the only time you ever get Kaposi sarcoma is from HIV and AIDS onset. What it is, you don't really know, you just know it's a thing. Treatment is pretty good, except you can't cure it. So they target the reverse transcriptase in HIV through nucleoside reverse transcriptase inhibitors and non-nucleoside reverse transcriptase inhibitors. Basically, they just either a competitive or non-competitive inhibitor, the same target, basically. And there are also protease and fusion inhibitors, which are targeting different aspects of the treatment. You can get a triple therapy and a dual therapy, but that's not important for you guys. Importantly, no one should really die from HIV these days, especially in Australia and realistically worldwide, I guess. And if you treat it properly, they won't even be infectious. So that's an important facet for there. HSV, so this is 2 types. So HSV1 is transmitted by saliva and causes oral cold sores as well as genital herpes, whereas HSV2 just causes your genital ulcers. 75% of these people may be asymptomatic, but the others will have a primary lesion 4 to 7 days after the infection. It can cause pain, itching, burn sensation, very similar to a UTI. And these heal over 3 to 4 weeks, but it's very common for them to come back, is a thing. Beyond that, not too much importance. It can cause serious problems in neonates, so that's why I think women get screened for it before they are, or when they are pregnant. Diagnosis is done on a PCR, and treatment is through acyclovir, the clovir drugs, and the condoms are used to prevent it. But fundamentally, that's kind of, I think, the important facets of that. Okay, so some bacterial causes of STI. So these are 3 that are important because they like asking kind of like buzzwords for them. So chlamydia, gonorrhea, and syphilis, or treponema pallidum. Haemophilus ducreyi is not really common in Australia and doesn't get talked about much. Those are some 2 interesting facts about it, I guess, more so than anything. All right, so chlamydia. So importantly, chlamydia is an obligate intracellular pathogen, as you can see in this little picture here. It's my own picture, the whole thing. But they're inside the cell. That's kind of important. There's a whole bunch of them, but realistically speaking, just know they're intracellular. That's your buzzword for this. Symptoms are observed 7 to 14 days after infection with a watery mucopurulent discharge and dysuria. However, that like clinical symptom is generally hard to distinguish between all the different types of bacterial cause of STIs. It can be asymptomatic, which is kind of a bad thing, especially for females. And it's worse for females because the complications that arise from these are also worse in females. So pelvic inflammatory disease, chronic pain, ectopic pregnancy, and infertility are all possible results. Your diagnosis can come from an ELISA or a PSR or cell cultures, and it's a curable disease with azithromycin and doxycycline, which are both just antibiotics. All right, moving on. So gonorrhea. So gonorrhea, importantly, again, is a gram-negative diplococci. So they present with like STI sort of symptoms, and they have a gram stains in the gram-negative diplococci. It's this, so Neisseria gonorrhea. It generally enters, I guess, via the vaginal or urethral mucosa, and it does all that kind of thing. But realistically, this is the only thing you need to know on this whole slide. Females are often asymptomatic, and again, that's bad because of the complications that can arise. So they're very much the exact same sort of complications. So PID, chronic pain, fallopian tube damage, and infertility. Because it's hard to determine clinically what the differences are, PCR is a good way of distinguishing that if you can't get that gram-negative intracellular diplococci stain or culture. It's treated with intramuscular ceftriaxone with azithromycin, and it is a notifiable disease, as I guess you do contact tracing and things like that for. Also check for the other STIs, such as chlamydia, because it is a likely co-infection. All right, and then finally, syphilis. So syphilis is also known as Treponema pallidum. If you don't know that already, know it, because it's kind of important. It's a gram-negative spiro shape, but that's not really a buzzword they ever use. So it's like pink and spirally, basically. But it critically has 4 stages of primary, secondary, latent, and tertiary, to where tertiary they can cause neurosyphilis and cardiovascular syphilis, which I will talk about in a second. Transmitted through sexual contact, and incubation period is 9 to 90 days with an average of 2 to 4 weeks. Okay, so symptoms. So primary presents a painless primary chancre, which is basically just like one lesion ulcer thing. Incredibly important is that it's painless. So if it's painless and it's a lump, then it's probably only really going to be syphilis. Nothing else is really a painless lump thing. It can present on the cervix, labia, or urethra, or on the penis, or on the anal rectum. It can be on other random sites too, but they're less common. Secondary is a highly infectious rash that occurs after it resolves in 3 months. So if they have a rash, that is no longer primary syphilis. That means they've had their initial primary chancre, probably ignored it because it wasn't hurting or anything like that, and then developed a secondary occurrence. Latent is kind of just when it kind of chills in your system and doesn't do anything. So that's why I haven't really talked about symptoms. There's no symptoms for it. But tertiary is when it gets really bad. So if you have tertiary syphilis, this is not a good thing, and you kind of want to have treated before this stage. And there are 2 kind of major groups for it. So cardiovascular syphilis and neurosyphilis, where cardiovascular syphilis basically, it sort of infects the aortic valve and causes like, not really infective endocarditis, but like this kind of degradation of that kind of aortic valve and the kind of structure in the aorta around about that area. Neurosyphilis is when it goes into your brain and causes dementia and psychotic symptoms. And that's kind of like the important bits of syphilis. Diagnostics, there are 2 sort of tests. There's a non-treponemal test and treponemal tests. The difference is that non-treponemal tests don't look for directly for syphilis, whereas treponema tests will. There are a couple of types. So the rapid plasma reagin test and the venereal disease research laboratory test, just words, and the treponemal test, which is the ELISA, and the TPHA and the FTA antibody tests. These are both used in conjunction, and if you just know that you can be used, that's, I think, all that matters. The sensitivity and specificities aren't that incredibly important. Treated with high-dose penicillin, and they are urged to have safe sex and diagnosis and early treatment, as are the rest of the bacterial STIs. Other genital infections, we're basically at the end, so there's not much here. But Trichomonas vaginalis is a flagellated protozoan. It can cause cervicitis and profuse frothy vaginal discharge or soreness, but a lot of women will be asymptomatic. It's transmitted through sex, basically, and it's diagnosed through a PCR, first pass urine. It's treated with metronidazole, but it's a drug that you don't really need to know. And then finally, we have Candida albicans, which is a fungus, so a diploid fungus. And it can lead to thrush, vaginal candidiasis. I think the important thing on your symptoms is that it's a cheesy discharge. Nothing else really causes that. And I think, like, if you have other things that cause that, it will give you other clues for those things. Your predisposing factors are things that change the kind of normal flora of the vaginal canal, I guess. So your hormonal changes, any diabetes, reduced cell-mediated immunity, and antibiotic treatment will change, I guess, the makeup of the flora and increase the risk of a candidal infection. And it's treated with fluconazole or any other antifungal, but realistically, the most important factor here is the cheesy discharge. I think that's it. So, yeah. So, did we have any questions, any queries, any concerns? I will stop the recording here.